moving on, our next speaker is Dr. Juan Pena. He's been practicing at maternal fetal specialist since 2021. He holds a Bachelor of Science from the University of Miami, a Master of Public Health from the Icahn School of Medicine at Mount Sinai, and a Doctor of Medicine from Boston University School of Medicine. He completed his residency at Wake Forest Baptist Hospital and a fellowship at Mount Sinai Hospital in New York. He's originally from the Dominican Republic, but he now resides in Dunwoody with his wife and 3 children. He enjoys working out and training in Brazilian Jiu-Jitsu. Please welcome Dr. Juan Pena for a talk on hypertension in pregnancy. I think he's getting his microphone.
Can you all hear me? Perfect, excellent. Thanks for that introduction. Yes, so like I said, Dr. Rubin's talk is going to be very, very difficult to follow. Really excellent talk. I just want to say thank you to Gretchen and everybody here. Thanks for having me. I like to start all these talks just to being appreciative. I stand on the shoulders of giants. I see OBs that I work here with, cardiologists. There's an attending that I did residency with here also, so it's a real honor for me to be here, so thank you for your time. Okay, so yeah, I don't have any disclosures, and I really wanted to make this talk relaxed and to try to give you guys usable information, so feel free at the end to ask away. High blood pressure is a big issue for me as a maternal fetal medicine physician, and you'll see some of the epidemiological data that I'm sure it's a big issue for you all as well. So the 4 things that I really want to focus on today is firstly, really understanding the diagnostic criteria for chronic hypertension, and this is important so that we can accurately identify those patients that should be treated, should be referred, should be taken a look at, and in a busy OB practice, having clear definitions may be helpful. The second thing that I wanted to review was the major results from the CHAP trial in the New England Journal of Medicine in 2022 that I think is very helpful for clinical practice. I think our current generation of OBs, there's controversy as to when to treat, when to not to treat, and that article really clarified that. I did want to spend a little bit of time talking about the common medications that can be used in pregnancy, that are frequently used in pregnancy, and I want to highlight them so I can give you guys some confidence in how to use them. And then finally, briefly talk about some alternative agents that can be used if you're still having issues and you don't have either perinatology backup or cardiology backup to help some of your patients. I like to start talks that are case-based. So I want to spend some time introducing a patient that I think is very typical for what we see in our practice for chronic hypertensive. I'm sure you all as well. So this is a 32-year-old patient who's para 2. We're seeing her at 19 weeks for her initial consult and her anatomy scan, and she has a history of chronic hypertension that was diagnosed prior to pregnancy. Her blood pressure at her first OB visit when she was 12 weeks was 156/98. She stopped taking her nifedipine when she had a positive pregnancy test, and I hear that story frequently. Her anatomy scan, or the baby's anatomy scan, was normal. It's got a well-grown fetus. So before we sort of start thinking about this patient, I want to make sure that people are aware. I think most people here know this intuitively because you're seeing it in your office, but I think it's important to understand national data. So this is looking at sort of the prevalence of hypertension nationally. This is NHANES data. So the NHANES, if you're not aware, I think the CDC does it, I forget. They'll set up these mobile health screening places nationally. They'll call people, So it's a pretty good representation about what's happening in the population presently. This is from 2017, 2018. I think this is the most recent data I checked last night. They hadn't put more newer data. But as you can see, a lot of people have some form of hypertension, period. And the bar graphs make it clear that hypertension, the prevalence of it increases with age. One thing that's helpful to see is that for all women, when they're above the age of 18, 13%, so about 1 in 10 of the patients that we're going to see in our office are going to have some form of hypertension. That proportion increases with age. So the second bar graph, so we're looking at the graph on the far right. So for women that are 18 to 39, which is the bulk of people that are doing OB, are seeing, almost half of those patients have hypertension. This chart, I think, also is well known. I mean, the media talks about this, how the prevalence of some of these conditions has a ethnic/race-based component as well. So you see here in non-Hispanic blacks, the prevalence of hypertension is much higher than people who are not. I think this is a very important graph as well for some of the more experienced. But I remember when I was a resident just talking to more experienced OBs that they would be shocked that they were having patients that had hypertension. But it seems as though the prevalence of any hypertensive disorder, including hypertension, preeclampsia, is increasing. And this last one I like to always think about because treating hypertension really helps save lives. So this is the proportion of deaths in hospitalizations during delivery where any hypertensive disorder was part of the diagnosis. Maybe not related to the death, but the patient had hypertension. And so almost a third of patients had either preeclampsia, chronic hypertension, on their chart at the time of death. And so I think for me is why I take sort of hypertension seriously. I'm very into definitions when I write my notes and when I kind of talk to people. I think it helps me make decisions. So I sort of review this frequently, these definitions, and I think it's important. Many times we do see patients in the hospital towards the end of the pregnancy, very high blood pressures. We're trying to really decide, hey, does this person need to be delivered at 34 weeks? Can we wait later? For a family, that's a big difference, right? There's a big difference between delivering a baby who's 34 weeks versus delivering a baby who's 37. Everybody in this room knows this. For me, as a resident, it would just be like, oh, that's easy, just deliver them. Blood pressures are high, whatever, baby's got to get out. But now that I've been practicing and really meeting people who have had premature babies, I have neighbors who have had premature babies, I'm very diligent and disciplined with the diagnosis because those 3 weeks, even with steroids, steroid complete does not mean term, it's a big difference. So this is straight from the ACOG practice bulletin, so this should not be controversial. So the diagnosis of chronic hypertension in pregnancy is any patient that comes into your office that has diagnosed with hypertension prior to pregnancy or has elevated blood pressure before 20 weeks of gestation. And I talk to patients about this 20 weeks of gestation thing all the time. It's not a magical number. I looked at it in Williams, Crease, I don't know where they came up with that number, but it's there. I think that the 20 weeks of gestation is helpful for me personally, so when I'm seeing patients in the hospital or doing consults, I'll often look through their hospital record, look back, and see, hey, have they been to the ER? Have they gone to see the primary care doctor or went to urgent care? It's really important to try to document, has there ever been an abnormal blood pressure before 20 weeks? And patients often say, well, I was nervous, I was this, I was that, all the time. But I remind patients that for better or worse, when people come see me in my office, many times I'm giving them information they don't want to hear about. It's either a baby with a very bad anomaly, something bad. Their blood pressure is always normal. So I can be going into a room and trying to counsel a patient that has, they know, they're coming to see me because they know there's an anomaly, anencephaly, bad spina bifida, a stillbirth. Their blood pressure is always normal. Or times where I've been on the labor deck, laboring a patient, pushing, their blood pressure is always normal. So I think I talked to them, said, hey, so your body's telling you something when you have a high blood pressure. Another definition is that hypertension that is diagnosed in pregnancy and does not resolve postpartum 6 to 8 weeks. So this happens, you're a preeclamptic patient, you need to put them on meds to get their blood pressure controlled. You see them 6 weeks after, they're still needing the blood pressure med. You get them connected with a primary care physician or a cardiologist, and they're still needing meds after their delivery. This happens a lot because patients said, no, it's not hypertension, I just had preeclampsia. Well, are you still taking medicines? Oh, yeah, I took them for about 6 months, and then I ran out of the So it's important. I think it's also important to work through these definitions with the patients so that they can take some, understand what their diagnoses are, because these are very busy families, very busy women. If they don't treat their hypertension, they may have a stroke when they're 42. So, and then the numbers are important here, sort of. As you know, for ACOG purposes, abnormal blood pressure is a systolic blood pressure greater than 140 over 90. And I know Lee Padoff is over here, and he's probably starting to have agita about it. That's sort of what we're working with right now. I looked this up, this week. There hasn't been any new updates on these numbers. That's not to say that you shouldn't be aware that outside of the OB world, they're using different numbers. And part of that is because, when I talk to patients about, because they don't feel it. They don't feel their abnormal blood pressure. But I tell them, listen, the neurologists, the cardiologists, these folks have gotten really good at taking care of you when you come to the hospital in extremis. They're going to save your life. I don't think you hear this in the news, but it seems to me the mortality of people that has a stroke or an acute coronary syndrome is not as high as it used to be. But you get disabled. So I tell them, hey, this is serious. If you get a stroke, you're probably going to survive. But someone's going to have to take care of you for the rest of your life. So for us, this number 140 over 90, the cardiologists and the people outside of our world really are trying to get people diagnosed and are trying to treat hypertension aggressively because of the avoidance of morbidity. So just be aware of that. When I'm thinking about hypertensive disorders in pregnancy, I'm always doing this process. Okay, is this chronic hypertension? These are the diagnostic criteria. Can I find a blood pressure when the patient has not been pregnant? Can I call the PCP? Can I call the pharmacy? Hey, this lady says that she was taking the medicine she doesn't know about. This happens all the time too. What was that medicine? When did she fill it? This helps me kind of put people, I hate to say into boxes, but it helps me. So for review, there's 3 main buckets of hypertension. There's the preeclampsia bucket. So there's gestational hypertension / preeclampsia, and that's elevated blood pressure in a patient that has not had blood pressure disorders, prior to pregnancy, with or without proteinuria. The second box that I think about is severe range hypertension with or without preeclampsia. And the reason that I like that is because sometimes we don't know. Sometimes we may never know. Sometimes, perhaps this patient just showed up to our hospital, never had prenatal care, came from another state, we're not going to know. So in that situation, treating the blood pressure is paramount. It's not as important to me as this chronic hypertension. We can think about what we're going to do in a day or 3 to 4 days. So severe range hypertension with or without preeclampsia. So this is a patient that has severe range blood pressures, so systolic blood pressure greater than 160, diastolic blood pressure greater than 110, with or without preeclampsia. which we've defined prior. The third bucket is a patient that has preeclampsia that's superimposed on chronic hypertension. And clinching that diagnosis for me is, again, really doing the chart biopsy, really talking to the patient. Hey, are you sure no one has ever, and I use different terms, hypertension, high blood pressure, whatever it is that that population or that patient is used to hearing, I asked him about. Have you ever been on medicines? You know, try to do the work, the investigative work to really figure that out. And then superimposed preeclampsia, for me, is whether or not there's been a change in the proteinuria. And in the next slide, I'll spend some time talking about proteinuria because this always, we use it a lot. In fellowship, for some reason, when I was in New York, no one really cared about proteinuria. I don't know why. And so when I came here, I had this bias of, who cares, proteinuria? Deliver them. But as I've been practicing more and sort of working with, their cardiologists, it's really an important test to know. Okay, so back to our patient. What are the things that we will, or I will do in my practice when I see these patients with hypertension? First of all, I really try to talk to them about their hypertension. How long have they had it? What medicines have they tried? Do they have a primary care doctor? Do they not? Do they see a cardiologist? In Atlanta, we're very lucky. A lot of our patients who have hypertension are pretty well plugged in and do have someone who is seeing them. For me, it's really important to understand how long they've had hypertension, because if they've had hypertension for 5, 10 years, and they haven't had an echo, or they haven't seen a cardiologist, or no one has checked their creatinine, or no one has figured out why they have hypertension, I really try to get them properly evaluated. I'll make sure that they have a 24-hour urine collection or some type of assessment of proteinuria. And in Atlanta, our OBs are really good about this. Very rarely do they send them to us without a 24-hour urine, but if they don't, we will order them for that, even if it's just a urine protein to creatinine ratio. Because I need to know, hey, does this lady have proteinuria for 2 reasons. First, if they come later in the pregnancy ill, very high blood pressures, like we've mentioned, for me, deciding who needs to be delivered prematurely and who doesn't is a big part of what I do. And so understanding if there's been a significant change in proteinuria helps me. There's not a definition about what a significant change in proteinuria. I use a doubling. So if they had, a baseline proteinuria that was normal, but now it's like 500, that's a significant change in proteinuria. If their baseline, some of our patients with nephropathy or whatever is 600, and now it's 1,200, which I've seen, that's a significant change. That patient is different. The other reason is that proteinuria is abnormal, right? So, period. We can debate of what is normal protein, glomerular filtration rate in pregnancy, et cetera. We can debate about that. But if a patient comes to see you and they have an elevated protein in the urine from their 24-hour, that's abnormal. That needs to be evaluated. We may not have to do it during pregnancy. We can. And in our practice, if there is significant proteinuria, I will refer that patient to a nephrologist. But that needs to be evaluated and that needs to be worked up. I get a baseline CBC and a CMP. And this may sound basic, but you can learn a lot about what the hypertension is doing to this patient just with those 2 labs. The CMP will tell you what their creatinine is. And so if someone has had hypertension for any significant period of time, we all know, if their creatinine is 1, that's not normal. That needs to be, for people that don't take care of pregnant women, they may be like, 1, big whoop. But for us, a creatinine of 1, that's not normal. A creatinine of 0.9 is not normal. So you can learn a lot from the creatinine. And then obviously you understand where that patient is early in pregnancy when they're well. If later in pregnancy they get unwell, again, it helps me decide, hey, does this patient need to be delivered prematurely or not? I'm not as disciplined with an EKG and an echo. I have a rule of thumb. If they have had hypertension for more than 5 years and they haven't had either of these 2 tests, I do try to get that for them. If they've had hypertension for less than that, I don't. That's not evidence-based, that's just sort of what I do. I'm open to new ideas. Lee's gonna give a good talk later, so we'll see what he says about that. And the reason this is, again, anyone who has had hypertension for any significant period of time, you need to understand what the blood pressure has been doing to their end organs. So an EKG will show you, hey, does this patient have left ventricular hypertrophy? Are there abnormal Q waves that need to happen? And you need to have a baseline EKG, so let's just say, because this has happened, they come back later in the pregnancy with severe chest pain, and they have a normal EKG when you saw them early in pregnancy, and now all of a sudden it's abnormal. That's helpful for us as women health physicians, because I can't tell you the number of times I've had to call a cardiologist and say, hey, this lady has chest pain, is not normal, okay? And they're like, oh, no offense, Lee, but I say, this lady has chest pain, and she had a normal EKG early in the pregnancy, and now it's abnormal. I need you to come help me figure this out. So that's for that reason. An echo also will help you say, hey, is there left ventricular hypertrophy? Some people with long-standing hypertension will have diastolic dysfunction. The management of those patients outside of pregnancy is different. Right? Someone who has diastolic dysfunction, they may want to rate control them better. Someone who has left ventricular hypertrophy, there's other medicines that are important for that patient to be put on that will reduce the risk of morbidity and mortality. So for those two reasons, I make sure that those get done. Okay. So, should we treat hypertension in pregnancy? Okay. This question for a long time was controversial. And partly it was controversial. I think perhaps traditionally our patients did not have these issues, so we just didn't know. And in 2014, this meta-analysis really looked at this question and what was known at that time. So hypertension is a number. In my opinion, it's an important number, but it may not mean that the patient is unwell. So what this meta-analysis looked at was about 4,000 pregnant women and looked at, I think it was, 31 trials of looking at whether treating or not treating hypertension. And what was learned from the meta-analysis is that treating hypertension, and treating was not clearly defined. Obviously, this is a meta-analysis, so treating had different criteria, but half the risk of developing severe hypertension. But it really did not have any effect on the probability of preeclampsia or on fetal and neonatal death. No effect on preterm birth before 37 weeks, and again, this is a very big thing for us. And also did not have an impact on whether or not there was an increased risk for gestational age babies, which at the time was a big sort of understanding, because it was thought that, hey, if we overtreat these patients, the babies will get small, et cetera, et cetera. But it really didn't answer the question is, does treating blood pressure improve pregnancy outcomes? So at that time, treating mild to moderate hypertension was controversial. So the NICHD really started to look at this question in a randomized controlled trial in the late 2010s, early 2020s, to answer this question specifically. And this is the CHAPS trial. This is open source, the New England Journal of Medicine. Whenever they have these big trials, anybody can access them, so it's there. I think it's important for people to review it. But it was a randomized controlled trial that meant to treat, there's an active treatment group and a control group. And the active treatment group was aiming to treat patients to a blood pressure less than 140/90. And the standard treatment, which was the control, was to withhold treatment unless the patient was severely hypertensive as defined there. It enrolled about 2,500 women, and they used two drugs that we're all familiar with, labetalol and nifedipine. And the primary outcome was actually a composite outcome that looked at preeclampsia with severe features, a medically induced preterm birth prior to 35 weeks, placental abruption, and fetal and neonatal death. I'm sorry, I've tried to fix this slide multiple times. I don't know why it doesn't project well. But what's important about this is understanding that the primary outcome was significantly less likely in the active treatment group than the control group. And there was no difference in the proportion of small to gestational age babies in the two groups. And the authors concluded that treatment of mild hypertension did improve outcomes in this patient population. And what's nice about these studies that NICHD does is that it involves people from all over the country. So where's the authors? Because that's the other criticism when we do, people hear about these type of studies. So, Alan Tita, I think, is in Alabama. This is Harvard. So it's people all over the country. And when you look at the study, it was very well balanced. I think most people in the study had an abnormal BMI. So it's like the patients that we see in our practices. So I think that this was a very well-designed study and really should give us confidence to treat hypertension. A couple of just highlights from the study. These are the questions I often get. You were able to be included if you had new or known chronic hypertension, and a big proportion of the patients in that study were diagnosed with chronic hypertension in this study. So what we see in our office, they come in, their blood pressure is abnormal, which, it has to be a singleton pregnancy and no preeclampsia. So they excluded patients with preeclampsia. So this is going to be important because this question comes up later. We'll discuss it. They did exclude patients who already came into the pregnancy with severe hypertension. And the reason they did that is because if a patient is coming in early in the pregnancy and they're already blood pressure is 170s or they're on multiple meds, that patient is more complicated than what we're used to seeing on a day-to-day basis. So those were excluded. Multiples, for obvious reasons, were excluded from the study. People who have had secondary hypertension, and that's people who have renal disease, the dialysis-associated hypertension, people with hormonal problems. And they also excluded women that had diabetes, CKD, cardiomyopathy, which I think is important, right? Because these are the patients that we're seeing. These are the patients that we're seeing every day. And then they excluded patients that had abnormal babies. So back to our patient. The two questions I always get are, should I treat the hypertension with these numbers, and what drug to start? For this patient, I think, yes, this patient needs to be treated. And my preference is to start with nifedipine. Obviously, for her, that's what she was taken prior to the pregnancy, but my bias is to use nifedipine, and I can talk to you a little bit about that when we discuss each drug individually. And again, this is from the practice bulletin, so this should not be controversial. The 4 drugs that are commonly used in pregnancy that I often hear about are nifedipine, also called Procardia, labetalol, methyldopa less. I haven't seen that in many, many years, but I put it on there in case anybody had any questions. And I also put hydrochlorothiazide because I sometimes will see patients that are started on something by their primary care doctor, and that's at times the go-to drug that is used. I like nifedipine. I like it, one, because it works. It generally is very well tolerated by patients. Some people will have side effects, so some people will have increasing edema, which can be an issue for us as obstetricians. I have heard that patients sometimes get headaches when they get put on nifedipine, but in general, it's pretty well tolerated and safe in pregnancy. The dosages are 30 milligrams per day, and you can titrate that up to 120 milligrams. Personally, if I'm getting up close to 90, then I'm thinking I need some help. There's something else going on here. Let's think about another drug. It's preferentially used once a day, so for patients who are busy moms, have a lot going on, or have issues with adherence, this is a big reason why I like this drug, because they just take it once a day. They can take it in the morning, they can take it at night, whenever they can take it, as long as it gets taken. I personally like this drug. The way that I write this is I'll write nifedipine, extended release, 30 milligrams once a day. I'll do dispense 90, so I give them a 90-day supply and 6 refills. The reason I do that is because I know we're going to see them throughout their pregnancy, they're going to get delivered, and then they may not see us again for another year or two. But that gives them, so 90-day supply, 3 refills, that's like a year worth of medicine that they don't have to call another doctor for ever. And I think that's important because they just need to take the medicine, okay? This is a safe drug. You know, it's not going to hurt them. It's also what the cardiologists prefer with respect to reducing morbidity and mortality from hypertension. It's got a very significant reduction in morbidity and mortality that's not seen in some of the other drugs that we're used to. And that's why I like it. The second common drug, labetalol, again, very common for us to use. It is safe in pregnancy. In my personal experience, it tends to be less well tolerated than nifedipine for 2 reasons. You have to take it a lot, and the dosages that are needed to really, really treat hypertension, people have side effects. So the doses start around 200 milligrams per day, but you can go as high as 2,400 milligrams per day. And this drug should be dosed 3 times a day. So it's it's like the effect starts wearing off around that 6th, 7th hour mark, and then they have rebound hypertension. My preference, if I'm going to write this drug, as long as their pulse is normal, is to start at 200 milligrams 3 times a day and go up on that. I feel like that's a good dose to really see if this drug is going to work for them. Hydrochlorothiazide, I put it on here because I often see this, patients that come to see us when they get their hypertension treated by people that are not as in tune to pregnancy. It can be used in pregnancy. I have to be honest, I often will take them off of it. I don't know why, but I do. But it's a second and third line agent. There's a lot of controversy about what it will do for breast production and breast milk production and all those things. So, and then you have to follow electrolytes, which can be hard if the patient is busy and all this other stuff, because you need to make sure that their sodium is okay. So it's a little bit trickier to use, in my opinion. So that's why I usually don't like it. But it is a good drug. Again, it has significant morbidity and mortality benefit. Dosages start at 12.5 to 25 milligrams daily. You really should not go up higher than 25 milligrams unless there's some other extenuating circumstances, or, you want to make sure you're checking their electrolytes. The safety profile gets a little bit dicier after 25 milligrams. And like I said, follow the electrolytes. I put this here because, again, just for historical purposes, I think I've seen this once since I started practicing in Atlanta, and I never saw it in New York or North Carolina. But it's in the practice bulletin, so I wanted to highlight it. This is a traditional drug. There's lots of safety data. It's not well tolerated. You need really high dosages for this to work, and people have side effects. And I don't think it works as well to treat severe hypertension. There's a couple of other agents that are a little bit, I like to say, esoteric with treating high blood pressure. If I'm starting to think about these drugs, at least in our center, I will call a cardiologist to get some more help. But you may see these being used. Hydralazine is an alpha blocker, and many times patients who have left ventricular dysfunction or the cardiologist really needs to work on their afterload, they'll use that drug. Clonidine is an older drug, and it actually surprisingly works very well. So sometimes this may be helpful in a patient that has very bad blood pressure, we'll say at 25, 28, 26, 27 weeks. You're very confident of the diagnosis. This is not superimposed preeclampsia, and you really want to give them a chance to prolong the pregnancy. This drug works really well. Doxacycline is another sort of esoteric drug that I've used in very severe hypertension, like emergently. That can be helpful. The ACE and ARBs I put on here just to make everybody aware. This is not something that we really should be using in pregnancy, so I like to make sure that we talk about it. There are a lot of benefits from ACE and ARBs. I think the issue becomes is if you start a patient on this at the end of the pregnancy or in the postpartum period, they're going to get pregnant again. And then they're going to stop taking this medicine. And then they're going to come in with very high blood pressures. So I put it on there just so for everybody is aware, but it's not a preference of mine. So back to our patient. I did restart her on her previous nifedipine. Her blood pressure when she saw us was in the 150s, so that that's mild to moderate hypertension. That patient should be treated. Her baseline labs are normal. Her EKG and her echo was normal, and her 24-hour urine protein was 100 milligrams. And I think that's it. I wanted to give enough time for questions because this is sort of what we do on a day-to-day basis. We get calls about hypertension. I showed you the problem that we're dealing with, and so I wanted to have enough time so that people wanted to ask questions and whatnot.
Juan was actually an internist before he became an obstetrician, so he
Yes.
is a glutton for punishment.
Yes. My wife was not happy.
Hi, good morning. I'm Desiree McCarthy Keith. I'm an REI in Atlanta. Excuse me. We have the opportunity to optimize patients before they get pregnant. We do our best to do that, but just wanted to hear your opinion about pre-pregnancy consultations. We refer a lot, but I know that y'all are very busy, so just want to hear what you say.
Yeah. So, we do see patients for preconception counseling. So I think of it as 4 domains when I do preconception counseling. First of all, specifically for people who have hypertension or some of these metabolic disorders, they don't like me talking about this, but I tell them the best thing that you can do to achieve, a successful pregnancy with IVF or whatever it is that you're going to do is to optimize your weight. So I always start all my conversations with that. And it really takes me only 10 seconds to tell them, even if you just walk during the commercial break just get up out of the couch and do some steps during the commercial break. That may sound silly, but it is very helpful for you. So I really encourage them to be optimized from that perspective. So normal weight. Secondly, if they do have hypertension, I spend a lot of time telling them that the drug that they're on, and 99% of the times they're on a drug that is appropriate for pregnancy, is safe for pregnancy, and I try to give them confidence that they should continue taking this drug because treating their blood pressure is the second best thing that they can do to optimize their pregnancy outcomes. The third thing is general health things. I make sure that they are up to date with cancer screening. We have seen an uncomfortable amount of breast cancer in our pregnancy in pregnancy in our practice. So that's the third thing. And the fourth thing is I make sure that they understand the benefit of low-dose aspirin once they achieve the pregnancy, because it's a safe intervention that can significantly reduce the probability of preeclampsia. So those are the 4 things that I talk about when optimizing a pregnancy. If they haven't had an echo and they've had hypertension for a long time, I like to make sure that that gets squared away as well.
Thanks so much. I'm Champa Woodham. I'm an MFM at MCG. I know there's always the debate of what we consider to be, in terms of the 24-hour urine,
Yeah.
what is nephrotic range and when to give anticoagulation.
Oh,
what are your thoughts about that?
Yeah. So there's very strict criteria for the diagnosis of the nephrotic syndrome, but broadly, you have to have nephrotic range proteinuria, and I have to look it up every time. I think it's 3 grams in 24 hours. And they have to have either a low albumin, and when you see the low albumin, that means that they're losing so much protein that, as you know, the liver, it produces the coagulation factors. So if the albumin is low, then they're at risk. And so there's some strict criteria. I have to look it up every time, but those are the 2 things that I think about.
Thank you for a wonderful presentation, Dr. Keisha Callens from the Macon area. Just more so a couple of comments. Clonidine, I love that you mentioned that And I had a patient once who was teenager, 18, and we kept changing her meds and really figured out she couldn't swallow pills, but she didn't
Yeah, oh
say
yeah,
anything.
it's a patch.
So the patch is an alternative to consider
Yeah.
because we want to set our patients up for success. The other two things are just making sure patients have access to a blood pressure cuff so that they're monitoring. I have patients take a picture of the blood pressure and, bring it in when they come so I can monitor to see
Yeah.
what it looks like. And the last thing is the importance of nutrition. So I cannot tell you how many times I've dumped ramen noodles in the trash when I go into a patient's room. And
Yeah.
so asking them what they've eaten before they arrive.
Yes.
Have they had a bag of Lay's potato chips? And so the educational component is extremely important because we can give them all the medicine in the world, but if their salt intake is excessive, if you eat ramen noodles and it's a square,
Yeah.
that's like 1,800 milligrams. And
Yeah.
so just really adding that into our conversation is really important.
Yeah, 100%. And actually, I did practice as an internal medicine physician for a long time. And I think the reason why I like doing obstetrics is because when you're trying to counsel a 65-year-old man about stopping smoking that he's done for 30 to 40 years, is impossible. But when you're talking to a young patient that's pregnant and you spend literally, for me, it doesn't take that long, 5 minutes, saying, hey, treating your blood pressure is important. You're not going to die, but you may get a stroke. Who's going to take care of you? You can impact that patient, for that family, for the rest of their life. And I know I didn't make it such an issue in the talk, but yes, talking about lifestyle changes, walking. I like, just do steps during commercial breaks. Whatever they can do it gets the ball rolling for them.
Hi, thank you so much for a wonderful presentation. It was really awesome and well needed. My name is Ashley Teagues. I'm a REI from Atlanta at ACRM. So we see a lot of patients before they become pregnant, and sometimes, no one's ever taken their blood pressure in the past few years, and so I feel like diagnosing chronic hypertension a lot. You mentioned that there are different diagnostic criteria in pregnancy versus pre-pregnancy. So can you update us on the most recent guidelines of diagnosing chronic hypertension? Is it 130 over 85?
130 over 80.
80.
Yeah,
130 over 80?
I know.
It keeps getting lower and lower. Okay.
Yeah, I know.
So 130 over 80, we tell people all the time to go home, take a diary, send it back to us.
Yeah, that's appropriate. And, like 120s over 70s, they're saying it's like pre-hypertension, stage 1. And I think of that has to do with, this is the morbidity associated with untreated hypertension. Like I've seen studies about looking in a population of the people who are diagnosed with hypertension who are actually treated, and it's appalling, like something like 10 to 20% of patients with hypertension are not treated. So I think that's why they're doing it.
Okay.
Why they're making it less and less, more and more tight.
What would you recommend?
Yeah, I think
for
it's,
us, like
yeah.
blood pressure diary, looking at those values, and then,
Yep.
We're often sending them to their primary care doctor to start
Yeah.
them on medication, or I guess
Yeah.
we can even start them.
This is what I would say in your environment. I would try to get that patient referred for a couple of reasons. I think you have enough to worry about with. This is a great talk, really. Like I've had forgotten how complicated IVF is. But you just thinking about it and having them do a log and getting them referred to treatment makes them understand, like, hey, this is important for me. This is part of my evaluation. This is part of what I need to do to achieve a healthy pregnancy. And just doing that is, I think, enough.
Yeah, and they need to be seen long-term, so.
Yeah.
Okay, thank you.
Does that answer your question?
Yes, that's
Okay,
great, thanks.
Hello, Juan. I'm Daniel Estevez from Lawrenceville, Georgia. And I'd like to make a commentary regarding how, in my practice, I select what type of antihypertensive medication I initiate my patients, as your practice receives a lot of my referrals.
Yeah.
And you might see that sometimes some of the patients come with one versus the other. And I like to subscribe to a rule, the Rule 55. The Rule 55 states that when you're evaluating a patient with hypertension, you should try to determine if it's a high cardiac output hypertension versus a high peripheral resistant hypertension. And so when you have the difference between the systolic blood pressure, when you subtract from the diastolic blood pressure, if that number is 55 or higher, that suggests high cardiac output hypertension. And it's thought, or my thought is that a beta blocker in that setting would be preferable. So I would start with that. If the rule is less than 55, then that would suggest a peripheral resistant issue, and that's when I would do the calcium channel blocker like nifedipine. So if you see some of my patients come in flip-flopping one versus the other, it depends on what their initial blood pressure is at that time of initial evaluation.
Yeah, no, it's all good. I mean, I have biases, but my biases is to get the patient treated. And I think that's a very good way of thinking, because it is true. Part of the reason why I get them an echo is to kind of suss out some of these nuances, and Dr. Estevez's point is very well taken.
Thank you.
Hello, I'm Teresa Bird from Marietta, and I just had kind of a question and a comment. I know we're focusing on hypertension in pregnancy, but it's pretty well established too that the patients who have hypertension during pregnancy and the surrounding time don't actually have normal hearts later. So there's pretty good data in the cardiology world to say that even that transient hypertension that they've had led to heart disease later on. And so there is a push. I know we've gotten push from the cardiologists on our team to make sure these patients get sent to cardiology postpartum to manage their blood pressure. And so they've actually been recommending that we really treat their hypertension aggressively in the 6-week postpartum period. Okay. What are your feelings about that? And I don't see a lot of people doing that, and I'm trying to urge, especially with postpartum and maternal mortality, really push us to more aggressively treat hypertension in the postpartum period. So what are your feelings and thoughts on that?
Yeah, I mean, I think the majority of the patients that we're seeing, I know I spend a lot of time in our Lawrenceville office. A lot of those patients are being sent to a cardiologist. I don't know how, when you say aggressive, meaning like making like, are you talking about this number, or just making sure that they're engaged?
Less than 130 over 80, less than 120 over.
Yeah, I mean, I don't go that low, but I am definitely open to learning new skills with that perspective, yeah.
And actually, Dr. Padoff is going to speak to
was
that
gonna say
today
that.
because he's developed an incredible program in
Yeah.
Atlanta where we do send those patients to cardiology, because there is really good data now coming out that shows that these women will have long-term health issues, and maybe not even that long-term, maybe in their 40s and 50s.
Yeah, and the numbers that we look at postpartum is looking at blood pressure. That's a dynamic number, and we'll talk about what happens, and it also depends on whether it's a new preeclamptic versus chronic hypertensive and so on, because some of these women, their blood pressures will turn on a dime, and so you got to be careful of being aggressive, let's say in a new preeclamptic that's on a slew of medicines and you send them home. The real issue is, there's a gradation if you have gestational hypertension, gestational diabetes, all the way up to preeclampsia, future risk of heart disease, whether it's the chicken or the egg, whether it's concomitant risk factors, whether it's cause and effect. But that's a population that needs to be aggressively, and we'll mention it, I'm trying to talk cardio-obstetrics in an hour and a half over the next 2 days. But that's a big area that we've done preventive-wise. We have what we call maternal heart health clinic that we started about 12 years ago. And the data's been there about this for years, and it's just now really getting known. But again, these women are more likely to end up with premature coronary artery disease, heart disease, so on, whether it's the same factors causing them to be predisposed to preeclampsia or preeclampsia causing some of the effect. You still picked a population to be very aggressive with risk modification, exercise, diet, sleep, things that people don't get after they deliver a baby, things like that. And we just try to educate them. So we have a nurse practitioner-driven clinic where she spends 15 minutes educating integrating lifestyles, teaching them how to check their blood pressure. One of the things that just as Juan talks about exercise, the other thing I do is teach them about how to check the blood pressure, make sure it's an accurate cuff, make sure they're sitting for 5 minutes, make sure they're not upset that they didn't watch CNN or Fox, whichever one they like or don't like, it doesn't matter. You know, you want them in a calm setting. And so, you know, it is an important time, but again, every patient's different.
Kathy Bonk, Atlanta. I'm a generalist, and this is my generalist soapbox. I cannot tell you how many 42-year-old people with chronic hypertension who had IVF and developed gestational diabetes, I said, it's time to schedule your induction now, and they're like, their face just goes blank. They need, all you specialists, every specialist in here, tell them they will not see their due date. Pitocin is not the enemy. It is their friend, just like their blood pressure medicine. So please, please, please.
Yeah.
Yeah, and I agree. And I
ditto.
would also say the 45-year-old that we get pregnant that has chronic hypertension and diabetes, if we're not treating them when they're in their 50s or 60s and their child's 10 or 15, they may not be around. So this is really important.
Ditto.
And Dr. Perry wants me to talk about postpartum Medicaid extension. You know, that is unique. I mean, not every state has this opportunity.
Yeah.
They can get sent. They can get paid for. You know, it's not, they do not have to live in the abyss of no health care after they have their baby.
Yeah.
Good morning. Thank you for this presentation. I'm actually a resident at MCG, and I was wondering if you can comment a little bit on how you differentiate superimposed preeclampsia with severe features from exacerbation of chronic hypertension, especially for someone who doesn't have baseline labs. And in the setting of CHAP trial, composite score being largely driven by the diagnosis of preeclampsia with severe features, and preterm delivery, I'm assuming, likely due to that diagnosis.
Yes. Sorry.
That's our average patient.
Yeah, it's hard. I mean, I think the point is very, very well taken. There's not a right or wrong answer. So I try really, 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 really hard to do the legwork to say, hey, just make, let's make sure what's happened before the pregnancy. We don't have a 24-hour urine baseline. Is the EKG abnormal? So if you have someone who has left ventricular hypertrophy, there's a reason why that happens. So perhaps maybe that patient gets put in the chronic hypertension bucket if it has that. Is the echo abnormal? That may be a patient that gets put in the hypertension bucket. And there's always the benefit of waiting, right? You can see how that patient does. As long as you're able to get their blood pressure in a safe range, you can wait. You can say, hey, we've done this, we've done that, the blood pressure's stable now, the proteinuria is normal, we don't have a baseline 24-hour urine, they've gotten steroids, we've watched them for several days, the labs have been fine, the patient feels well. That patient may be somebody who has hypertension that didn't know before. Preeclampsia is gonna preeclampsia. Does that make sense? So that's going to be different than a patient that comes into your labor deck like super hot, very high blood pressures, you're pushing drugs, you're going through the protocol. A preeclamptic patient is going to become preeclamptic, period. So taking your time, making sure you kind of review things. You don't have to deliver everybody. You can kind of just say, hey, let's treat the blood pressures, let's figure it out. This is going to be that's a big transition when you get from residency into practice, right? Because in residency, you're just putting out fires. In practice, we have the benefit to, first of all, we know all RBs. We know kind of how they work with their patients. We know that the OB will tell you, like, hey, this patient is very sick. Like, I don't think that this is hypertension. I think this is something else. The nurses will tell you, like, hey, I've been watching this patient for 12, 18 hours. This really doesn't smell like chronic hypertension. And having that time, like in practice, there's no shifts, right? Like, there's no shifts. So you'll get the opportunity. So I think if you're not sure, it's okay to stabilize the patient and think about it.
I was going to make one comment, which is to think of preeclampsia as a systemic disease,
Yeah.
that blood pressure is a component of.
Exactly.
And that's real important that people think of it that way.
Yeah, and preeclampsia won't get better.
No.
It'll get worse.
No.
So if you treat the hypertension and the patient's stable, then it's probably not preeclampsia. But if it's getting worse, then you can deliver. So I agree. We, oftentimes we do a lot of watching and waiting.
I know it's annoying to the OBs, but.
Great talk. Quick question about 81 versus 150 versus 162 milligrams
Yeah.
of baby aspirin.
Yeah, I think everybody does that differently. What I do in my practice is I sort of put people in like bad preeclampsia bucket. That person is going to get bad preeclampsia, and the person is going to get garden variety preeclampsia. Obviously, like we're MFM, so it's different. So people, for example, lupus patients, people who have chronic kidney disease, people who have like APLS, people who have had very bad preeclampsia in the past, a 24-week delivery with help, those kind of patients, I'm more likely to put those patients on 162, which is what you can get in the United States. People who have the sort of traditional risk factors for preeclampsia, I will do the 81 milligrams. But that's my heuristic. That's how I do it.
I don't think there are any guidelines in the States. I know in Europe they're doing a lot of research on this, and hopefully we'll gain some knowledge from them. Their aspirin comes, I think, as 100 or 110, so they actually use a higher dose than we do. They also stop it at 36 weeks, and we continue it till term or till delivery. I don't know the right answer on that either.
Okay. I think if, I'm going to be here, so if anybody wants to ask me questions, I'm around. So thank you, and thank you very much.
Great, thank you. We've had 2 wonderful talks this morning. Now it's time to take a break. I think we have 30 minutes to get up and stretch, and please use those go see those vendors because they are the ones that make this conference possible. Thank you.